Good evening, everybody, and welcome to this daily Maverick webinar on COVID-19 vaccines and the COVID-19 vaccine rollout. Thank you for joining us on a special and auspicious day. It was the day that President Ramaphosa spoke at the Zondo Commission and answered questions, but I think more importantly for tonight's purposes, it was the day on which we resumed vaccinating our healthcare workers with the Johnson & Johnson vaccine after a 2-week pause in that rollout. And I think that makes it relevant and timely for us to host another discussion about the COVID-19 vaccine rollout, where we are, what your certainties, uncertainties, questions may be as viewers. So we're very fortunate this evening, you can see them both in front of you, to have two very distinguished scientists as our guests, world-class scientists. First of all, we have Professor Koleka Mlisana, who's in the center of my screen. Prof. Mlisana is the Executive Manager for Academic Affairs, Research and Quality Assurance at the National Health Laboratory Services, and she is an expert in HIV, in tuberculosis, and somebody who has been working in the field of virology and viruses and pandemics, epidemics for a very long time. Professor Koleka, thank you so much for being with us this evening. Our second guest is another professor, Professor Barry Shube. Barry Shube, I've known for a long time. We were just talking about our experiences in the early days of the HIV epidemic. Professor Shube is Emeritus Professor of Virology at Wits University. He was also the founding Executive Director of the National Institute for Communicable Diseases, and he is at the moment the chairperson of the Ministerial Advisory Committee on COVID-19 vaccines. I should also mention that Professor Mlisana is the co-chair of the overall Ministerial Advisory Committee on COVID-19. So not only do we have two distinguished scientists, but we have two of the people in the hot seats who are advising our government on how we respond to this dreadful pandemic. So with those introductions over, I'm going to jump straight in, and I'm going to come with the question first to Koleka. We agreed we would address each other using our first names. But before I do, let me just say this, that this morning, MEC Mkhize addressed the Health Portfolio Committee in Parliament. He told the Health Portfolio Committee that all systems are ready to go. Millions of Pfizer vaccines are due in our country, I think in the next days. The Johnson & Johnson vaccine pause, as I've mentioned already, has been lifted. I think there are now 3,000 vaccination sites that are in various stages of readiness. 500,000 people of 60 years old or older have registered on the EVDS system. So unlike where we were 2 or 3 months ago, we are on the cusp of something beginning to happen. But even as we ready ourselves, it's quite clear that there are still many questions that people have about the COVID-19 vaccines. We asked two professors for questions for this webinar. We got 9 pages of questions. They're all very, very good questions. They are very diverse. They're very genuine questions. But what it showed to me is that there is a lingering hesitancy, that there's questions that people still feel that they need to be answered. And we're going to have to answer those questions properly and quickly. So I'm going to start by going back a little bit to the beginning, Koleka, and ask you, we are now going to use 2 particular vaccines, the Johnson & Johnson vaccine and the Pfizer vaccine. Can you tell us why you think those vaccines are safe as a scientist, and also a little bit about their effectiveness in helping us to manage this epidemic. So over to you, Professor Mlisana, to begin with.
Okay, good evening, and thank you very much, Mark, for inviting me to this webinar, and good evening to everybody who is online. It's really a pleasure and a joy that we could, sit like this and have a conversation about these important issues. Before I come to your question, so we had to make this very clear, Barry and I, the differences between the MEC for, the vaccine MEC versus the MEC for COVID-19. And we were actually told that there is no overall MEC. It's actually the MEC for COVID-19. So it looks at all the other issues, and then there's a vaccine MEC, just so that everybody is clear. But anyway, yes, currently we're talking as a country about the two vaccines, which is the Johnson & Johnson as well as the Pfizer vaccine. Now, if we're looking at these two vaccines, people will remember that the Pfizer vaccine is actually the one that is stage that when injected into human beings, it then tells the cells to form a protein that is similar to that of the virus. And remembering that behind vaccination, all we're trying to do, we are priming the body to actually stimulate an immune response so that when the body gets exposed to the virus, there's already an existing immune, immune cells that have been formed. So what the Pfizer vaccine is this mRNA, which once on injection, it then stimulates the cells to form these proteins that look like the virus, and therefore the body thinks it is the virus and develops these immune responses. Now, the immune responses can be different. It could either be an antibody response, or it can be, what we call a cell-mediated immune response, okay? So that is the Pfizer vaccine. Whereas if we're looking at the Johnson & Johnson, the Johnson & Johnson is actually using what we're calling a vector. And this is a methodology that we are more familiar with. In fact, it's the same, kind that was used, for Ebola vaccines. So basically what this one does is that it is the same, it's a DNA message that's actually packaged in what we call a viral vector. And they have used an adenovirus, which is harmless to human beings, which then is what is used and it gets injected, and the same, DNA message results in formulation of the similar, protein. So basically, those are the two differences between the two. Now, a lot of people are always a bit concerned about the Pfizer and the Moderna because it is new technology, and we all agree it is new technology. It's therefore going to be a matter of time for us to see, what the impact, but what I also want to just stress is that this being an mRNA, when it gets injected, it really does not get into the nucleus, but it actually remains in the cytoplasm, and that is where protein synthesis occurs. And RNA generally, they are very easy to destroy, so it really will be destroyed by the cell within a short space of time. So when we're looking at safety, remembering that when we're talking vaccines, there's always the from animal trials, and then we do human trials. And if we're looking at safety data, really all this, if we're looking, for instance, at Moderna or Pfizer, and even the J&J, there has been no safety concern per se, but most of the adverse effects that have been seen, generally, it has been either, pain on the injection site, a little bit of muscle, or even sometimes, a joint pain, headaches now and again. But these are always around the vaccination time. And within a few days, those symptoms resolve. But there really were no significant adverse effects that would cause an alarm. For instance, with the Pfizer, there were a few, patients that actually had severe allergic reactions, and that is why then it was important to make sure that we ask patients before they get vaccinated, ask participants whether they've had a history of allergic reactions or not. And the same thing with Johnson & Johnson. There really have been no major concerns of safety, except for the recent scare, which actually caused us, to put a hold on the vaccination. But we can come back to that, later on. Now, looking at efficacy, remember that, for instance, the Pfizer, it was one of the first vaccines to actually, be rolled out. And therefore, when it was tested, it was also before we got, to know that there were variants that were going to emerge. So most of the data is actually coming before there were variants that were emerging. And if you're looking at, efficacy, for instance, the Pfizer was sitting at 95%, efficacy, which is really great. And if we're looking at the Johnson & Johnson, sitting at 65%. Now, what we sometimes tend to forget, and I'm going to stop now, is that, the safety, sort of the efficacy of vaccines, really, for me, and you, Mark, when I had those efficacy rates, because people say if one is 65 and one is 95, doesn't that mean then Johnson & Johnson is less effective? But I always want to remind people, take us back to HIV days, when we actually rolled out male circumcision as prevention for HIV, we were looking at efficacy results of 50, 60%. And right now we have rolled out male circumcision. So really for such prevention methods, 60 and above, that's great, efficacy. And so really, if you're looking at the two that we have as a country, and the advantage of Pfizer, of Johnson & Johnson, is that their results actually, by the time they came out, we already had the existing, variant that was, identified in the country. Let me just end there.
Thank you. And another advantage of Johnson & Johnson, I understand, is it's a single dose.
Exactly.
It's a single shot.
Exactly. It's a single dose, yeah. As opposed to Pfizer, which is actually 2 shots. And so, and also, in fact, when I was just looking at safety and efficacy, there was the other advantage as well of Johnson & Johnson is the fact that it can be stored in an ordinary fridge, as opposed to Pfizer, which requires, minus 70 freezers and making sure that you transport it at minus 20. Okay,
Professor Shube, would you like to add anything? Would you put your hand on your heart and say, I'll take either of these vaccines? Koleka, would you say the same?
Absolutely. Whatever comes first. I haven't been vaccinated yet. Whatever comes first, it goes into my arm.
I have.
You have been vaccinated.
Yeah.
Prof, why do people get these side effects? It seems to me, Koleka, you're correctly saying people do get side effects. That's common to all vaccines, I understand. It's not unique to the COVID-19 vaccine, but you're saying that most of these side effects are fairly short-lived. Prof. Shube, why do people, what's your body telling you when you get these side effects? And given that we know that there are some serious adverse reactions, and it's a big, real concern to many people, what does a person do to tell if an adverse reaction is a serious adverse reaction that warrants medical attention?
Yeah. Well, first of all, thanks very much, Mark, and thanks for the invitation. Can I just correct one thing?
Yes.
Koleka was talking about our Macs, the Mac. I used to always say that the kind of main Mac, or the Mac which we always used to call it the Big Mac. So there's the Big Mac and there's the vaccine Mac. But okay, I'll rest there. But just in terms of side effects, Mark, I think we can really kind of group 3 groups. Okay, there's the group of side effects which are reasonably common. And that is as Koleka said, the pain at the injection site, maybe a little bit of swelling, maybe the lymph gland might get up a bit. The next day you're a bit feverish, you're feeling fluey, your muscles are sore for a day or 2. And that's the immune response. Because what happens when, you must remember, these are foreign proteins which are being injected into your body. Your body needs to react to it in a positive way, of course, because now it's producing, as Koleka very graphically said, an immune response which is protective. But nevertheless, it does also produce other intermediate chemicals, interferons and cytokines and these kind of things, which are also protective, by the way, but give you that flu feeling. Now, when you get flu, the flu is due to these intermediate molecules. And they're actually a positive thing, not a negative thing. Okay, you might say, you're feeling lousy and so on, but maybe a bit of aspirin or Panado will kind of take away that subjective not feeling so well. So that's the one group. That's reasonably common. I'd say a large chunk of people, if they get the flu vaccine, or if they get this COVID vaccine, or they get many other vaccines, will have this immune response with intermediate chemicals giving that kind of feeling. Then you get the rare side effects. Koleka mentioned about the clotting. We can maybe go that in a bit more detail. Those are very rare. That's 1 in a million, for example. There's the allergic. Some people have a very strong allergic response. The immune response goes to a pathological extent, not a protective, but pathological extent. And that can give you the various allergies. And the more severe is what you call anaphylaxis, where people actually collapse. And in very rare circumstances, if you don't get quick enough, it can be fatal. But this is very, very rare. And both the clotting and the anaphylaxis seem to be more common with the Pfizer. And I say more common, I'm talking about 2 to 6 per million doses. Very, very rare. But more common than, for example, the clotting, which is 1 per million. That's usually associated with AstraZeneca and with the Johnson & Johnson, with that adenovector that Koleka was talking about. So those are the rare complications. No, those are the extremely rare complications. Let me make it more accurate, more precise. And then the third are what people worry about, and they're non-existent. And a lot of people worried about, we've got this mRNA. Maybe it's going to change our DNA 20 years down the line or 10 years down the line and so on. I've been in this vaccine game now for a couple of decades now, and colleagues overseas, I actually discussed it with colleagues in the States, and they all agree that, these side effects occur within a short time after vaccine. A short time, say about a month. There's never been any vaccine history, and we've had many, many vaccines going into people's arms. There's never been a long-term side effect, say years later or even many months later. And COVID's not going to do the same. So the third group is a non-existent group of side effects.
Thank you. Thank you very much, Barry. I saw a comment from somebody called Catherine Robertson, and I don't want us to talk in acronyms because it'll be a self-defeating discussion if this is about effective communication. She said, we keep on talking about the MAC. What does the MAC mean? MAC means Ministerial Advisory Committee. And it's a group of scientists and social scientists who advise the Minister of Health on different aspects of the COVID response. And there is a specific Ministerial Advisory Committee on vaccines, COVID-19 vaccines, which Professor Shube is the chairperson of. Okay, so these side effects are common. They should be taken seriously. You're all agreeing on that. There can be serious, rare side effects. Will you be monitoring them? Once we've started vaccinating millions of people, how do we know that something isn't going badly wrong? That there's not actually, despite everything you're saying this evening, that there may not be thousands of people who are showing severe side effects. Koleka, back to you for that one.
Okay. In fact, I probably will ask Barry to comment as well, because, generally as a country, we actually do have bodies that monitor any immunization adverse effects. Right now, the current Sisonke study has been doing that extensively, but there's going to be a shift and there's sort of like a handover, remembering that we have got the regulatory body who actually are responsible for monitoring and ensuring that, all those safety concerns about any medication in the country, for that matter, are captured. So there are actually, for instance, there's a national advisory group on immunization. There's also a group that looks specifically at post-immunization, reporting. So there are various bodies that are in existence that will then make sure that there is that monitoring. And Barry, I don't know if you want to add to that.
Can I just say, Barry, because maybe you can answer this as well. I hear what you're saying, Koleka, but isn't there a problem that people are generally find these bodies inaccessible? They don't know where they are. They're bureaucratic. They're unfriendly, and so they don't trust these bodies. So if monitoring is going to be so crucial, with the vaccine rollout? How are we going to do it in a way that is different, that builds trust and is accessible as well? Perhaps, Prof. Shube, you can come in on that as well.
Okay. Well, as Koleka said, I mean, there is the way of monitoring. But let me take one step back. There are the two vaccine implementation programs. The one is the Sisonke, which is for the healthcare workers. That is what we call a phase 3B implementation program or study. We don't normally call it a trial, because a trial you have a placebo arm and you can't do the comparison. There's no placebo arm in this. It's actually an implementation study.
Placebo arm, just explain quickly for people.
Oh, sorry, a control. That was somebody that you compare what you're testing. In other words, the vaccine against the comparative population, and you compare how side effects or efficacy and so on against that group. That's the placebo. So the Sisonke program, however, is a quite a tightly controlled program, because it is an implementation study. It's a study by implementing the vaccine, how it's going to work and how safe it is. So the healthcare workers are given a voucher, and they are given contact details. And I think in terms of there's a discipline which is called pharmacovigilance. Pharmacovigilance. Pharmaco means, pharmacy, medicines. Vigilance, as the name implies. In other words, studying the drug, or in this case, the vaccine. And the pharmacovigilance for the Sisonke is very tightly controlled and works very, very rigorously. I think that's pretty accessible. Then we have the rollout. The rollout is going to start from the 17th of May. Now, the rollout phase 4. Now we have the phase 1, 2, and 3. 3 is the one which proves whether it's efficacious and safe, and then it gets licensed. And phase 4 is post-licensing marketing or pharmacovigilance. Now, I do take your point about the bureaucracy. I do take your point about the accessibility. That is something which shouldn't happen. There should be an easily accessible, seamless way of reporting what we call adverse events. Now, I think I must explain the difference between an adverse event and a side effect. Can I do that?
Yes.
Okay. An adverse event is something which, as the name implies, is pathological. And the adverse event happens soon after getting the vaccine. Now, what the pharmacovigilance needs to do is ascertain, is that adverse event a side effect? The side effect means it's a negative thing which occurs as a result. In other words, it's causally associated, not necessarily temporally associated. Because many events, of course, in life is not always a bed of roses. We do sometimes get sick. We do sometimes, unfortunately, God forbid, have accidents. And sometimes they occur at the same time. Now, it's the job of the people who are doing the vigilance to kind of ascertain, is it simply an adverse event? Or is the adverse event a side effect? Now, all this comes into the pharmacovigilance. And to answer your question, yes, all I can say is, fortunately, I'm not responsible for that. I can do from the sidelines. That must be seamless. It must be easily accessible. It must have people that can be controlled, because that's critically important if you're going to monitor how the vaccine works and how safe it is.
Excellent. So you'll pass that recommendation on from us to the minister and to various people in government.
I hope he listens. I hope he listens to us.
Well, I hope we hope so too. Yeah. Okay, so this is dealing with adverse events, with side effects. As I understand it, we paused the Johnson & Johnson vaccine because of these rare blood clottings, because it had been paused in the United States. It's back on again there. There's been an investigation. Everybody is happy that the Johnson & Johnson vaccine, whilst it may have these adverse effects, is a safe vaccine. I've noticed that with the Johnson & Johnson vaccine, however, that SAHPRA, the South African Health Products Regulatory Authority, has said that vaccine should not be used in pregnant women and breastfeeding women. Can you explain why that is the case as simply and as quickly as possible? And whether doesn't that potentially exclude tens of thousands of people from from vaccine access? I don't know which one of you wants to jump in on that one first.
Koleka?
For me, I would just quickly say one of the reasons is the fact that if we're looking at who actually experienced those rare events, they were actually common amongst young women. And so that was one of the reasons to say, and also remember, the Sisonke is still an implementation study. And therefore, the regulatory body had to be cautious to say, you know what, especially because the majority of the individuals who had these rare events were younger women of childbearing age. And they were actually, Sisonke team were about to extend the protocol to include pregnant women. And that's why the regulatory body said, at this point in time, after this scare, let's exclude pregnant women. But, as to whether going forward into the future, right now, they're actually...
Very quickly, just to add to what Koleka was saying, is that I think women there are some women, of course, who have become pregnant, healthcare workers who've been vaccinated. They really need not worry at all. And I'm saying that from a couple of reasons. First of all, experimental animal experiments have shown that there's absolutely no harm either to the pregnant animal or to the developing fetus. That's the one thing. Second of all, in countries where there have been mass rollouts, for example, in Israel, United Kingdom, again, where they've looked at, of course, there have been quite a number of pregnancies, there have been no problems. And also from a biological mechanism, these are killed or inactivated. They're not live virus vaccines, like, for example, measles and rubella is. So there's no biological way in which it can either affect the pregnancy and also can't affect the infant as well. And so if you take all of these things into account, plus the fact that we do give killed vaccines, flu vaccine, for example, to pregnant women, we give whooping cough vaccine to pregnant women. It's the same ball game. So it's really a precautionary thing, just until we get enough data. And as Koleka said, data is being collected on the vaccine pregnant. I'm absolutely sure that eventually it will be recommended for pregnancy, because COVID itself does carry a risk, very small risk, but a tangible risk to pregnant women.
Great, thank you very much. Now, unfortunately, we're just going to have to move the discussion on. I wanted to discuss these questions of safety and the issues of adverse events, side effects, because it's been in the public domain and lots of questions have been asked about it. I'm going to take you into a discussion about the benefits that we expect to get from these vaccines, from a mass vaccination program. But before I go there, I just want to pick up a couple of questions that are being asked on the chat line. We're getting many questions and they're very diverse. So I want you to just give very quick answers to a few of them.
Sure.
Should 55-year-olds join the phase 2, Koleka? That's from... Should 55-year-olds join the phase 2 rollout?
Okay. Now, very briefly, the whole idea of using the age, it is because, we had to look at the age and look at the comorbidities. And really, when we're talking age 60 and above, it is just because if you're looking at, studying the population, the majority of people who have got comorbidities are 60 and above anyway. And in fact, when they were looking at the various, variables, they realized that age became the most significant one. In that if you start with 60, you then are going to cover a lot of people with comorbidities. And remember, it's not just going to be 60, for a long time, but within a very short space of time, I think it's about a month or so, I can't recall the specifics on the plan, then it will be people who are above 40. So really, this is just to say, for a start, let's start with 60. The next group is going to be everybody above 40. And also, if we're taking everybody above 40, that actually covers probably almost 80% of people with comorbidities. And then only we will go to those that are 18 and above. So really, that's the rationale. Is it 55? Is it 56? Is it 60? You've got to reach a point and cut off and say 60 and above. Then the next lot will be 40 and above. And it's a matter of a few weeks difference.
Okay, so what you're saying is that we'll start at 60 and above, but we will move fairly quickly down and hopefully catch younger people with comorbidities as we move down the age brackets. That's basically. So the question, should 55-year-olds join phase 2? They should certainly sign up for vaccination. They won't qualify for the vaccinations that will start on May the 17th, but within a very short time, they will qualify and they should make themselves available. Dina Tatley asks, how much time is needed between a COVID vaccination and the flu vaccine? Barry, do you want to, indeed, should you have both?
Yeah, the recommendation is 14 days, an interval of 14 days between the two vaccines. It's really because the side effects, you don't want the side effects to multiply. We do generally, I won't go into, I think let's leave it there. But okay. I was going to say that there are some inactivated, we do get simultaneously, but I think with COVID, we want to have a 14-day interval.
Okay. And Judith Favish says, I've had an anaphylactic reaction to a vaccine previously. Does that mean I'm at risk of having a similar reaction to either of these two vaccines?
Well, I think it's very important that he does warn the vaccinators that he has had this history, so they are prepared for it. That's number one. Number two, normally people wait about 15 minutes after getting the vaccine. This person should wait at least a half an hour at the site before he moves off, just to make absolutely sure. But important to warn the vaccinators.
Thank you. Should a person, Koleka, who has already had COVID-19 still be vaccinated?
The answer is yes. We're recommending that they should be vaccinated. The reason being, remember, we also don't know how long the immunity remains after infection and, for that matter, after vaccination. And so even if one has had COVID, we recommend that you do get the vaccine. And what we know as well is that actually the vaccine may act as a booster and ends up increasing the immunity in that person.
Okay, so categorical on that. Are people going to end up having vaccines, COVID-19 vaccines every year in that case?
The answer to that question is we don't know, Mark. We really don't know. Because firstly, we need to monitor. We just need the time to see how long even immunity post-vaccination lasts. And we don't know also what the effects of the emerging variants are going to be. So it might as well be, we might end up like similar to the flu, situation, but we really don't know. It's a matter of time to see first. Then we will see whether we need vaccination. How often? Is it going to be every year? Is it going to be every 2 years? Time will tell.
So there's a lot we don't know, and we don't dispute that. This is a virus that we have now known for, I think, not even 18 months. We're learning about it. We're learning about our treatments, our vaccines all of the time, and we adapt our strategies as we go along. But we have to have these strategies because millions of people have already died worldwide. Tens of thousands of people have died in our country. And as somebody said in the one question, we've vaccinated 293,000 healthcare workers with the Johnson & Johnson vaccine. Have we seen any benefits yet in those healthcare workers? Can you say, or is it too early to say that those vaccines have protected those healthcare workers? They're perhaps less healthcare workers getting COVID-19.
Yeah, I think we can definitely say that there's been a tremendous benefit. So far there have been 20 what we call breakthrough infections. In other words, people that have been infected in spite of being vaccinated. Now they might have been because the actual immunity really kind of kicks in. It starts kicking in 2 weeks, but it really becomes effective at 4 weeks. So they might have got infected in that period of time. But overall, there's been a marked reduction in illness amongst healthcare workers. I say there have been so far 20 breakthrough infections out of the 290,000, which is remarkably low. And of course, we just need to look at countries which have rolled out, and you can see how effective the vaccination has been.
Thank you. Koleka, would you like to add to that?
No. Actually, I think Barry has just covered it. And obviously, then there was a halt. I suppose now that there's been a halt, we're going to need to catch up and increase the numbers and see, the long-term effect thereof. But really, there is a significant difference, which is what we're really hoping for, because, in case, we end up with another wave, at least we want to make sure that the healthcare workers have got protective immunity.
But then that links to a couple of questions people have asked. We've got a catastrophe going on in India at the moment. A few people have said, well, India is vaccinating, and India is vaccinating, I believe, millions of people or tens of thousands of people, yet they've still got this explosion of COVID-19. How do you explain that? Professor Shube first.
Yeah, when we look at, can I just have just 2 minutes? Because I think this is a very, very important question.
Okay.
And that is that, there are two kind of groups when you look at the aims of immunization. The one aim is personal protection, and the other is community protection. Now, personal protection is never 100%. There is always a gap. And for that reason, people still have to carry on with the masks, the distancing, the hand sanitation, avoiding crowds, etc., because there still is that risk. Now, and that's why these epidemics are still going on when you have, 10% of the population immunized, 20%. There's still a large number of people that haven't been protected. It's only once you get to community or population, or what you call herd immunity, that you stop the circulation of the virus, that you control it down to the level that's not going to cause those epidemics. Now, India, I haven't got the figure for India, but I think it's probably about less than 10% of the population. It's an enormous population. It's well over 1 billion people. So it's a vast amount that they have to, get even a certain percentage immunized. So you've still got that vast gap of non-immune individuals, and even those people that have been immunized doesn't necessarily mean that they're not getting infected and passing on the transmission. That's the personal protection side. It's only once you get the community protection that you're going to dampen down. And we see it in many European countries, for example. You look at countries like Italy and Germany now, and France, where they've got 20% coverage and 10% coverage, and they've got severe lockdowns, severe restrictions. And again, obviously not in the scale of India, but certainly very severe epidemics carry on. United Kingdom as well, which has got quite an advanced immunization program, and they're still having the epidemic at a very high level, much higher than us, and much more restrictions that we've got.
Koleka, would you like to add?
No, well, just safe to say, really, it is true that, with such a dense population in India, and also there are the effects of the variants that are coming up, which we also then need to see whether those variants, how the vaccines that are being used in any country, really, how they actually respond to, how the variants to respond to those vaccines. So from cases in India.
And what you're both saying is that even after I have been vaccinated, you've been vaccinated, you're still going to use your mask. You're still going to
absolutely
practice social distancing, hand washing, hygiene, etc. And that is going to continue probably for many months, even years, until we have got to this point of population or herd immunity where we've really broken the back of this viral transmission. That's a critical message that you're saying. We use... Koleka?
No, definitely. Actually, thanks for raising that, because it really is an important statement that the community, the population of the country needs to know we are going to be using these non-pharmaceutical interventions for a very long time, because we're far from, reaching, the community immunity that we're talking about. So irrespective of whether you have actually had the infection, a natural infection, or you have been vaccinated, you still need to make sure that you put your mask. And whenever I say putting your mask, I want to say put it correctly, because it doesn't, it's useless if you're going to put a mask and it's below your nose. When we're saying use a mask, use it properly and make sure that you social distance. And for me, social distancing is an individual thing. Make sure you social distance and avoid big crowds, because we're not there yet.
So it's not a contradiction, Barry, that we get vaccinated, we get protection, but we still continue to practice non-pharmaceutical interventions.
I think, Mark, the kind of critical thing we need to kind of get everybody to understand is that vaccine is a very important, probably the most important, but only it's one component to stopping the transmission of the virus. The other component is human behavior. And the two of them is what we want to get to community immunity or herd immunity. But a vaccine on its own won't get to it, and herd immunity on human behavior won't get to it. I often get asked, what's going to happen in the future, 2022 and 2023? I think what we're aiming to do is change the personality of this coronavirus. We want to get enough people immunized that this coronavirus is going to eventually become one of the more trivial coronaviruses. We've got 4 coronaviruses which cause the common cold and a little bit of gastroenteritis and so on. That's something we can tolerate. We all tolerate the common cold every winter. And that's what we eventually want to get to. To get to that stage, we've got to have the combination of vaccines, which on its own will not reach it. We do have to supplement vaccines with human behavior. Once we get over that mountain, and this is now an endemic, what you call an endemic coronavirus, not an epidemic one, we will tolerate minor upper respiratory tract infections. It'll be one of the causes of the common cold, eventually.
Thank you very much. And just vaccinated. So we're seeing the evidence as population rollout begins to take place. The only thing is we have to start our population rollout, and that's where I'm going to take you in the last few minutes of this. But just before that. Yes, okay.
Just one very quick, because I think it's quite important. I don't want to kind of harm on terminology, but I think this is an important thing. There's a difference between efficacy and effectiveness.
Right.
Efficacy is what we get from a trial, a controlled trial. Effectiveness is how it behaves out in the field.
Lovely, thank you. I'm happily stand corrected as well. But that's important. Just one question Charles Atkins asked, did they handle my question regarding asymptomatic people being vaccinated? I think earlier on he asked, should you go for a test to see if you are COVID positive before being vaccinated?
No.
What's your advice here?
No,
you don't need to test it.
Shouldn't be.
No. Because like we have said, whether you Barry. Whether you have the disease or you don't, you need to take the vaccine. So there's no need for you to be tested before. So
the message is everybody should take the vaccine in accordance with the different stages of the rollout in our country, and that includes people with comorbidities. There's nobody who should not be taking this vaccine. Is that what you're saying?
Yeah, that's
these
correct.
Vaccines. Yeah,
and certainly totally agree with what Koleka is saying. And I've mentioned myself that there's no need to kind of screen for infection. If one has got asymptomatic infection and you get the vaccine, that's not a problem. But what often does come up, if somebody has recovered from illness, from corona illness, then we normally recommend they should wait about 3 months afterwards.
So normally wait for 3 months after being ill with corona illness. Sorry.
Yeah, correct.
Yeah.
Before you're vaccinated. Okay.
Correct. Yeah.
Koleka, anything to add on that point?
No. Okay. I'm fine. Thanks.
Okay. So one of the things that's concerning people at the moment, and we've been talking about it for a while, is we had our dreadful second wave of COVID-19, and we're anticipating a third wave of infections and obviously of illness and tragically of death. The rollout is due to start in a few days' time. Is the vaccine rollout going to make any difference to this third wave that we are preparing for, Koleka?
Okay, let me start off by saying, firstly, when we're talking about the third wave, we feel what is really going to determine when and how high we get the third wave has got a lot to do with behavior, human behavior. And so, we want to ensure that the rollout of vaccination kicks off as quickly as possible. But at the same time, it's going to be important, like we have been saying, for the individuals to ensure that they stick to the NPIs so that we bring down the possibility of an emerging third wave. Especially, we've seen these concerns, whether it was in Free State or Northwest, where you're getting these cluster infections. And so we really don't want to get that, because the last thing we want to see as a country is an overwhelming third wave whilst we are rolling out vaccination, because that obviously is going to put a lot of strain on the health, on the health within the country. And so really for me would be to say, let's just make sure that we delay the emergence of a third wave as much as is possible, so that we can get a significant amount of people getting vaccinated. And so for me, that would be, what has got to be important. That's the important message we need to send through. Barry, you want to add to that?
Well, no, I think you've said it very well. Maybe I can just say the one point. Of course, we don't know when the third wave is going to come about. And obviously when it comes about will depend on how effective the vaccine, how much vaccine we already got, particularly amongst our high-risk individuals, to stop them getting ill. You see, the main point, what we want to do with vaccination is stop people getting to hospital. We can tolerate mild infection. What we want is to stop people getting severe infection, because that overruns the hospital.
Allocated to the provinces. Can you be specific on the numbers which will be used from mid-May? Can you help us, Koleka or Barry? I saw, Glenn, that Minister Mkhize today, I've actually seen a slide which gives a great deal of detail on numbers per province. But can either of you two help us on this question?
Okay, I must say I don't have the exact numbers, Mark, but as you correctly say, the department has put a plan together. And what's going to be important, as you are correctly saying, is that when the minister talks about the plan, when the Department of Health talks about the plan, they need to make sure that they project those numbers. But really what has happened is that there are allocations. Firstly, we know how many doses are coming in from, for the J&J vaccine and when those are coming in. And then if I recall what the minister was saying, then there's going to be another over 300,000 doses that's coming in on the Pfizer every week, followed by 600,000 or so. I don't want to misquote this because I don't have that slide. I think the best would be to get that slide projected so that people can see exactly. But there's a very detailed slide showing what numbers, when they're expecting those, and then the further distribution according to the provinces. And what I do know is that actually each province is currently putting a full plan for themselves, because they have been given by the national department what numbers of vaccines are going to be coming them and how often, and their plans are being crafted along that. But I'm sorry to say, I just don't have the slide. It would have been much easier to project it for you so that people can have it. But it definitely is there, and the department has got that.
Barry?
Yeah, no, I can maybe just in the very short term say, the one advantage, of course, is that vaccine is being produced at a Koleka, am I pronouncing correctly, Koleka? Koleka plant, which was Port Elizabeth originally. And I know 1.1 million doses of Johnson & Johnson are already on their way they have to go to the National Control Laboratory for standardization and then distribute. So that's in the short term. And also 650,000 Pfizer are coming in the short term before the middle of May. So that's certainly enough vaccine to get the rollout going very, very substantially. In the very long term, of course, the minister is committed to getting enough vaccine of the two vaccines to cover the entire adult population. 41 million.
Yeah, so your message is the D-Day is May the 17th. That's correct. The date we've been told this next phase of the rollout will start. From May the 17th, there will be as much vaccines of Pfizer and Johnson & Johnson as we are capable of giving to people over the next several months, that those vaccines will be available in all of our 9 provinces in our rural areas as well as in our urban areas. I saw a few questions people were asking. Will people be able to go to their local Dis-Chem? Are they going to be? Is there going to be access to private facilities, public facilities, where people can just go along and get vaccinated?
Yes, I think that, and then distribution centers, even at stadia, at conference centers, at gyms, all the way down to retail pharmacies. Now, the kind of granularity, I don't have at my fingertips, but just the kind of the kind of plan has been gone to great detail. There are obviously a lot of gaps that still have to be filled in, but that's the general plan.
Great.
Koleka.
Well, it's not our job as the Daily Maverick or Maverick Citizen, but I'll try and make sure we report that slide with all of those details tomorrow to help make it accessible. But I think you would both agree that there's a big need to improve communication still around the vaccine rollout.
Absolutely. Absolutely.
Sure. Definitely, that's critical, Mark, because a lot of people are asking because they just don't have clarity. And I really think it's important for the department and even provincial departments for that matter to actually, tell the communities what the plan is. I must say, though, I actually managed to have a very quick peep in one of the slides that, were presented to us about the plan. So, come the 17th of May, we start with the 60 plus, and then a month later, it will be the 50 plus, and a month later, the 40 plus. So the actually huge, what do you call it? I mean, very high hopes that the department is hoping to reach, a maximum of like 250,000 vaccinations a day, because the target is that come October, the 40s and above would have been vaccinated by then. And therefore, the bulk, and people who have got comorbidities. So it really is a very high call. And what's going to be important, and as Barry says, this is definitely not just going to be the Department of Health. It's not just going to be a public health, issue, but there's a lot of communication and planning with the private sector as well.
Okay, I think the communication really needs to be upped. I mean, as I was preparing for this webinar, I saw it reported that 500,000 60s and overs have registered, which on the surface seems good, but 500,000, and I believe there are 5 million people in our country who are 60 or over. So it's actually a small fraction of people have registered so far for something which has a very, very immediate life benefit. So we're not getting there, are we?
Now, I think we've got to mention. I think we've got to mention that there are many elderly people who are not computer literate, and some who even aren't literate. But there is provision for them to go directly to the vaccination sites, where people will be there to help them filling out the necessary administrative requirements.
So if you go to a vaccination site, nobody's going to say to you, you didn't register on the EVDS.
There will be people
go home again.
No, not
definitely not.
No. I think there has been recognition that many people, particularly elderly people, will battle to kind of register on the site.
Okay. And Marion Jill Bregman asks, are they going to divide the over 60s into specific age groups, i.e. over 80s, over 70s, or are they all being lumped together?
All being lumped together.
Yeah.
Okay, so if you're 60 or over, register or just pitch up. You're entitled to a vaccine, you will receive a vaccine. That's what you're saying to us.
Yeah.
Yes. And can I also add, sorry, Barry, in fact, I was sitting at the Eastern Cape, a meeting, and they were saying there the same thing with the over 60s. If, for instance, they are going into old age homes, they will make sure that they vaccinate everybody in the old age home. So they're not going to skip if there's somebody who is 40 years old is working at the home. They will, otherwise it's not going to be cost effective. So if they come into a home, they will vaccinate everybody that needs to be vaccinated rather than having to go back for the next age group.
Okay, we're almost out of time. Stephen Cooper says KZN Premier gave out very different information regarding who gets vaccinated. He said over 80s, and then over 40s with comorbidities. We need one message not left to each province to interpret as to who gets first. I won't ask you to comment on that, but except to say that I think you'd all agree. We need one clear set of messages that come out from all levels of government and all sectors of society across the country.
Across all provinces, yes.
Across all provinces. Professor Shube, Professor Mlisana, we're almost out of time. I just want to ask you whether you have any concluding comments or thoughts that you want to offer to the people who've been with us tonight. I'm very conscious that we've left out many questions.
It's because these vaccines have been developed very rapidly and they're novel platforms. These vaccines are extraordinarily safe. And it's the very science which has kind of made these vaccines so readily available, which has got the depth to understand that they are safe, that they are effective, and just to encourage everybody to get vaccinated.
Thank you.
And for me, the choice between the two vaccines, really, they are the same of the same. The only thing that probably is going to cause a choice will be, for instance, if we're looking at the hard-to-reach areas, it makes sense to use the one that's one shot and also the one that's, can be, stored in the fridge. And therefore, really, don't worry which one you're getting of the two. We have got confidence in both. Thank you. And
will you be, as the two MAC chairs and co-chairs, will you be publishing on a daily basis from May 17th the number of vaccinations that have taken place, as well as by province and by area? Will you be providing that type of information?
Mark, I'm very much a part-timer in this, a volunteer part-time. Yeah. I think the Department of Health has really got the kind of administration resources to do that. I don't even have a secretary. I'm a one-man show in this office here. No, I think the Department of Health would need to do that.
But there is the intention to provide that information. Can we see?
Sure. Yes. Hopefully, that's an excellent suggestion that there is a running monitor of it. Absolutely.
Okay. Not just a running monitor. We want to know by province and, if possible, even by district, because it will ensure that there is equity in this rollout and that areas and people and groups of people don't get left out.
Absolutely.
I think, Mark, there's a lot of improvement, on data collection generally in the country, with the systems that have been put in place. And so I would imagine it should be easy, because if we've got the EVDS system, it will be able to pick up who has gone for vaccination, and that can be then segregated into various provinces. And I would imagine each province would want to monitor how they are doing. And so we expect those numbers as well.
I'll bring that suggestion to the MAC, in fact, as one of an agenda item. It's an excellent suggestion.
Excellent. Thank you. Well, Prof. Mlisana, Prof. Shube, thank you very much for the hour that you've given us tonight. I hope that your input has answered many questions, even though we haven't been able to answer all questions. But I hope that our public information systems will improve so that people are able to have all of their concerns and questions answered as we go forward with this critical vaccine rollout in our country. But thank you for the roles that you are playing. Thank you also for the roles that all healthcare workers are playing in this country, still in our hospitals and in our clinics, helping people who have been infected with COVID-19 to survive this illness. Thank you to all of you who've joined us and stayed with us tonight. Thank you to Nicole from the Daily Maverick, who does all the behind-the-scenes hard work. I just say from my side, if people want to put it into your diaries, that on May the 12th, we will be having another webinar with the Chief Executive Officer and the Chair of the Board of the South African Health Products Regulatory Authority to talk about the role of SAPRA in all of this, but also in relation to things like ivermectin and cannabis and medicine regulation generally in this country, because there's been a lot of confusion and controversy. So I've offered them the space to come and explain exactly what their role is and how they take decisions. So very much appreciated, everybody. Professors, good luck with your important work. I am going to sign us all out now. Thank you very much.